Okay, welcome back. Chapter 16, Cardiovascular Emergencies. We have lots to talk about here. Be sure that you are clocked in order to get proper credit for this lecture. All right, so cardiovascular disease. Cardiovascular disease accounts for about 1 of every 3 deaths in the United States. It's killed a lot of Americans. It's the #1 killer, or has been a leading killer of Americans since the 1900s. EMS can help reduce these deaths by providing the following services. Obviously, encouraging a healthy lifestyle to our public and being that role model. All right, early access to medical care, and then training CPR. We need more lay people trained in CPR. And then the increased use of evolving technology in dispatch and response, and obviously equipment that we have available to us in the field. We also increased public access to defibrillation devices. We have defibrillators in most of all government buildings now. And then we recognize the need for advanced life support, and we encourage through our training the recognition of advanced life support and the use of cardiac specialty centers when they are available. All right, so a little anatomy physiology. We've talked about this in anatomy and physiology about the heart. The heart's job is to pump blood to supply oxygen-rich red blood cells to all of our tissues, okay, all the cells and tissues. It is divided into the left and right side. The left being the high pressure side, okay, and the right being the lower pressure side. Very good. All right, there's a good diagram of it. This is slide 6. This figure on this slide illustrates the heart and all the components of it. All right, so the atria receives incoming blood and the ventricles pump the outgoing blood. So in total, in necessary, the blood leaves each of the 4 chambers of the heart through one-way valves, which keep the blood moving through the circulatory system, okay? It's got to go through those valves. All right, so in the proper direction, those valves keep them going in the right direction. The aorta is the body's main artery, and it receives blood ejected from the left ventricle and delivers it to all of the other arteries that supply the blood's tissues. And here's your diagrams. Okay, this figure on this slide illustrates how blood circulates to the heart. Okay. All right, so the heart's electrical system, we haven't touched on that too much yet, so let's talk about that. The heart's electrical system controls the heart rate and coordinates the work of the atria and the ventricles. The heart generates its own electrical impulse starting at the sinus node. The impulse passes from the atria to the ventricles, and it automatically allows for spontaneous contraction without a stimulus from a nerve source. As long as impulses come from the sinoatrial node, the other myocardial cells will then contract when the impulse reaches them. If no impulse arrives, however, the other myocardial cells are capable of creating their own impulses and stimulating some sort of contraction. All right, so this is a good diagram. This figure on the slide shows you the electrical conduction system. This is the sinoatrial node. Okay, this is where everything begins. These are called the internodal pathways. There's 3 of them specifically. That way a signal can always travel down one of them. Remember, this is kind of like a one-way highway, man. This stuff goes down there and then makes things do what it's supposed to do. Each one of them, is capable of generating a rate, a specific rate. So now the SA node goes down the internodal pathway to the AV node. The AV node works its way down to the bundle of His, as you can see here. Okay. And then they branch off into the bundle branches, both left and right, down as far all the way down into the Purkinje fibers. All of these are wrapped around into the heart so that the heart can function properly and that it can beat in a coordinated effort to cause good contractions. All right, so the autonomic nervous system, ANS, it controls the involuntary activities of the body. The autonomic nervous system has 2 parts which normally balance one another. The sympathetic nervous system and the parasympathetic nervous system. Okay, so once you remember that, autonomic nervous system, ANS, has two parts, sympathetic and parasympathetic. All right, so the myocardium, it must have a continuous supply of oxygen and nutrients to pump blood. Increased oxygen demands during periods of physical exertion is supplied by the dilation or widening of the coronary arteries. Stroke volume describes the volume of blood ejected with each ventricular contraction. Increased stroke volume results in increased cardiac output. All right, coronary arteries are the blood vessels that supply all of the oxygen to the heart muscle itself. They start at the first part of the aorta, just above the aortic valve. They branch down into the right coronary artery. It supplies blood into the right atrium and the right ventricle, and in most people, in the inferior wall of the left ventricle. The left coronary artery supplies blood to the left atrium and the left ventricle and divides into two major branches just a short distance from the aorta. All right, here's a great diagram. It shows you all the coronary arteries that carry blood supply to the heart. It's very important for you to understand that you have left and right coronary arteries and the basics that they serve those sides of the heart. As you progress into paramedic school, there's a lot more detail on what tissues that these serve and how we can tell when somebody's having a heart attack based on our ECG recording which one of these coronary arteries are blocked. All right, so arteries supply oxygen to different parts of the body. All right, so the right and left carotid arteries supply the head and brain. The right and left subclavian arteries supply the upper extremities. The brachial artery supplies the arms. The radial and ulnar arteries supply the lower arms and hands. The right and left iliac arteries supply the groin, pelvis, and legs. The right and left femoral arteries supply the legs. The anterior and posterior tibial and perineal arteries supply the lower legs and feet. All right, so arterial and capillaries are smaller vessels. Capillaries connect arterioles to venules. Venules are the smallest branches of the veins. Vena cavae have to return the blood back to the heart to be reoxygenated. We call them superior and inferior, right? Superior above the head or above the heart, inferior below. Okay, superior vena cava and the inferior vena cava. Blood consists of red blood cells, which carry oxygen. They also have white blood cells, which fight infections, platelets, which help control blood clots or form blood clots, and then plasma, which is the fluid that cells float in. Blood pressure is the force of circulating blood against the arterial walls. Systolic blood pressure, this is the maximum pressure generated by the left ventricle. And then diastolic pressure is the pressure against the artery walls while the left ventricle is at rest. All right, so systolic, left contraction pressure. Diastolic, left resting pressure. There we go. All right, a pulse is felt when blood passes through the artery during systole. Peripheral pulses are felt in extremities. Central pulses are felt near the body's trunk. There you go. This slide, it shows you all the different locations. This is slide 20 of 115. Carotid, femoral, brachial, radial, posterior, tibial. Let's get rid of me for a second. And then the dorsalis pedis. The posterior tibial is behind the ankle, as you can see here. Dorsalis pedis is up on top of the foot. There we go. I'm back. All right, so anatomy and physiology continued. The overview of this last particular slide is number 21. Cardiac output is the volume of blood that passes to the heart within 1 minute. Heart rate times volume of blood ejected with each contraction is what we know as stroke volume. Perfusion is a constant flow of oxygenated blood to the tissues. Okay, constant flow. It's calculated, I mean, obviously perfusion is very, very important. Stroke volume is very important because without this, we cannot get oxygen and nutrients pumped around and waste gotten rid of quick enough. If perfusion fails, cellular and eventually the patient will expire because we're not getting rid of the waste. We're not bringing in enough oxygen to the cells. All right, so some pathophysiology. Chest pain, all right, heart-related chest pain usually stems from ischemia, which is decreased blood flow to the heart or an inefficient supply of oxygen and nutrients. Ischemic heart disease involves a decrease in blood flow to one or more portions of the heart muscle. If blood flow is not restored, the tissue will die. All right, so here we go. Arteriosclerosis or atherosclerosis is the buildup of calcium and cholesterol in the arteries. It can cause an occlusion of the arteries. It is fatty materials that accumulate with age. Usually, primarily, it has to do with our diet. A thromboembolism is a blood clot that floats through the blood vessels. If the clot lodges in a coronary artery, then you're going to have an acute myocardial infarction or AMI. That's the heart attack, okay? Those things, if we go back and look at it, the vessels when they break off, just like what we talked about in class. If that little piece of plaque breaks off, it's going to cause a clot, and then you're going to end up having a heart attack if it's in the coronary arteries. Coronary artery disease is the leading cause of death in the United States. We have lots of controllable risk factors such as obesity, high blood pressure, all kinds of stuff. And then we have uncontrolled ones such as males, age, that kind of stuff. So there's things that we can control and things that we cannot. Acute coronary syndrome, or ACS, describes a group of symptoms caused by myocardial ischemia. This includes temporary myocardial ischemia resulting in angina pectoris, which is a short, painful event, or a more serious condition, an acute myocardial infarction. Angina pectoris occurs when the heart's need for oxygen exceeds its supply. It creates a very crushing kind of squeezing pain. A lot of these people know that they have this because they carry nitroglycerin. It does not usually lead to death or permanent heart damage, and it should be taken as a serious warning sign. If you're already, and usually this happens on exertion, when you're out mowing the grass, doing something, playing with the kids, you end up getting a little bit of that chest squeezing. That means there's some narrowing of the arteries, and that you need to go see your cardiologist or go see a doctor. And then, of course, they may put you on nitroglycerin to relieve the pain. And if it does not go away after 3 nitroglycerins, then you've got a problem. All right, unstable angina, it's in response to fewer stimuli than normal. Stable angina is relieved by rest or nitroglycerin. Treat angina patients just like they're having a heart attack or AMI, because we can't rule that out unless you have a paramedic there to run some EKGs and that kind of stuff. Then ultimately, it can't be ruled out until you get to the hospital where they can do some lab analysis and then cardiac catheterization. All right, AMI pain signals the actual death of cells of the heart muscle. Once dead cells are dead, they cannot be revived. Once cardiac cells die, they do not regenerate themselves. Now, this is all being caused by a clot. So we use what we call thrombolytics, or clot busters. It will dissolve the clot and allow it to move on. Or they can go to the hospital or go to the cath lab and have angioplasty in the catheterization lab. Signs and symptoms of an AMI or acute myocardial infarction. AMI differs than angina. It's not always due to exertion. A lot of this comes on while they're at rest or while they're sleeping. And it lasts 30 minutes to several hours. It doesn't go away at rest at all. And it's not always relieved by rest or nitroglycerin. It will stay around. AMI and cardiac compromise are really very serious stuff. And they do have we may look at different types of physiology that tells us that, hey, this person may be having a heart attack, especially at a paramedic level. All right, so 3 serious consequences of AMI: sudden death, cardiogenic shock, and congestive heart failure. Dysrhythmia, which remember we talked about the electrical conduction of the heart. This is how the pattern of the heart works. It may cause some abnormalities that we call premature ventricular contractions, tachycardia, bradycardia, or ventricular tachycardia. Defibrillation, right? When we defibrillate somebody, you guys have done that now since you've had your BLS portion. It restores a normal cardiac rhythm. It does not prevent cardiac arrest. you were already in cardiac arrest. You have to be no pulse cardiac arrest for a defibrillator to be placed on you. And it ultimately can save lives, especially if it's used early. So initiate CPR until the defibrillator is available. Now this rhythm here, asystole, this is an absence of all heart electrical activity, and if you put an AED or a defibrillator on the patient, it will not shock. Nearly all patients that are in asystole do die. Cardiogenic shock, often caused by a heart attack. The heart lacks the power, it's worn out, man, to force enough blood through the circulatory system, and then it provides for inadequate oxygen to the body tissues, and ultimately the organs begin to fail. This is usually what kills your patient, is organ failure. This is often caused by a heart attack. The heart is so damaged it just can't pump enough blood to send it out to all the organs so that the organs will survive. Heart lacks the power to pump, man, just can't do it. You need to recognize this early. It is a form of shock, and it's related to the heart, so you need to know that this can be very, very deadly, and transport them properly. Congestive heart failure often occurs within a few days following a heart attack. It's because the heart muscle now is so weak, it just can't do its job correctly. The increased heart rate and enlargement of the left ventricle no longer make up for the decreased heart function. So the lungs now become congested with fluid because the blood's backing up into it, and may cause what's called dependent edema. This person's looking for something that's going to have to be implanted into the heart that will allow for the ventricles to rest until they can perhaps even get a heart transplant if it's that badly damaged. All right, so hypertensive emergency. This is a systolic blood pressure that's greater than 180. Sudden severe headache is a very common sign. Common symptoms include altered mental status and pulmonary edema. Not good. You get high blood pressure, you're looking to having a stroke, okay, or a dissecting aortic aneurysm. Either one of those could be deadly. So if you got somebody with a blood pressure that high, they need to be seen at the hospital. They need to go. Aortic aneurysm is the weakness of the wall of the aorta. It's susceptible to pop or rupture. Dissecting aneurysm occurs when the inner layers of the aorta become separated. Primary cause of this, uncontrolled hypertension. Signs and symptoms, they vary, okay, but we need to transport these patients quickly and safely as possible to the hospital if you suspect it. All right, so table 16-1, acute myocardial infarction versus a dissecting aortic aneurysm. This is slide 37. It goes through all the clinical signs of both AMI and dissecting aneurysm. Gives you a differential diagnosis platform. All right, so scene size up. Again, we're in the cardiac patients. All right, so the good old heart patient. Remember, we do this every single lecture now. We go through the specifics for heart patients on this, or whatever lecture it is on our assessment. Scene size up. Same as scene safety, same as anything else. It's going to be a nature of illness call, most likely. Don't forget, you can still have trauma because you can have a heart attack and crash your car. Obtain clues from dispatch, the scene, patient, and family, and bystanders. Gather all that history. General impression. There it is. Okay. If unresponsive is not breathing, begin CPR and call for an AED. Airway and breathing. Oxygen saturation less than 95%. Apply oxygen with a non-rebreathing mask at 15 liters. Not breathing or inadequate breathing, 100% oxygen with BVM. If they have pulmonary edema, we want to support with positive pressure using a bag valve mask or a CPAP device. Circulation, pulse, circulation, rate and quality. Pulse, skin, capillary refill, how do they look? Consider treatment for cardiogenic shock. Transport decision, sick or not sick. Decision is based on the ability to stabilize any life threats during that primary assessment. Most of these patients are sick patients. They need to be sent to a hospital that can manage their heart problem. All right, so history taking, investigate your chief complaint, your chest pain, difficulty breathing, obtain your sample history from the responsive patient, and use OPQRST. Secondary assessment, physical exam. You want to focus on cardiac and respiratory system, circulation, rate and quality, respirations, rate and quality, vital signs, measure and record the patient's vital signs. If unavailable, if available, use your pulse ox. We want to find out what's going on there too. That's good parameter of how well distal circulation is going on. All right, if the heart is not functioning well, distal circulation may not be too good. All right, then reassessment. Vital signs at least every 5 minutes or when the patient condition changes significantly. Sudden cardiac arrest is always a risk, so be prepared to have to perform high-quality CPR and the use of your AED. Reassess all your interventions and rapid transport to the appropriate facility. All right, so emergency care for chest pain, ensure proper position, give oxygen. Depending on protocol, you might be able to give them low-dose aspirin to get started. That is, you're thrombolizing the patient. You're giving them a thrombolytic. That's what blood thinners are. That's what aspirin is. It will help to maybe manage or get that clot loose. And you may assist them with their own nitroglycerin that's prescribed for them, assist them in taking it. Aspirin, the effects, you need to know them. We know that the effects of them, it causes blood thinning, and that's what we want. Nitroglycerin, there's multiple available forms. There's pill forms, there's liquid form. Mechanism of action, the mechanism is, that particular drug will cause vasodilation. It helps to reduce the pressure that's onto the preload of the heart. Side effects, headache, make sure that you ask them about any sexual enhancement drugs before you give it, because if you mix it with Viagra or Cialis, it's going to cause a massive drop in blood pressure. So that's one of the contraindications. All contraindications to any kind of medications, whether it's nitroglycerin or aspirin or anything that you want to help a patient with, is hypersensitivity. Do they have any allergies to it? We call it hypersensitivity to any medication. That's the #1 contraindication. You always have to ask that. All right, so administering, ensure the medication is not expired or contaminated, ensure the medication is prescribed for that patient. Wear gloves, all right, and then you're just going to give a little spray, or you're going to put the tablet underneath the tongue, and you can repeat up to 3 times every 5 minutes or until the pain goes away. If you've administered 3, that's it. No more. Okay, no more. Remember, you got to use your OPQRST to get that baseline of what their pain level's at before you start this, because you want to be able to ask them every 5 minutes, did it get better? What's the pain scale number now? All right, so cardiac monitoring, even though you guys don't do that, you're going to help us by putting on EKGs. For an EKG to be reliable and useful, electrodes got to be placed in the right place. Basic principles should be followed to minimize artifact in the signals themselves. You'll have an opportunity to practice that. Don't put it on body hair because it won't stick. Rub the electrode site with alcohol before application. This will dry any oils up. Attach the electrodes to the ECG cables before you stick them on the patient. It's much easier that way. And then confirm that electrode placement. These are your general guidelines. What we'll do for you folks is you definitely need to know how to put the 4-lead ECG on. White right, red rib, okay? And then you can say smoke over fire, okay? This is the black, all right? So you got the smoke, which is black, over the fire, and then your green is green to go. It's on the ground side, so it's over here on the right side. So just remember white, green, black, red. Easy enough. Now these are application of our V leads. This is when we're doing a 12-lead EKG. This is V1 here, okay? V1 right here, V2, V3, V4, V5, and V6. And we'll show you how to apply these to patients so you'll be familiar with it, because when you're doing your ride-alongs, they may want you to put this on for them. It helps. Everybody's got a job to do. All right, once the electrodes are in place, switch on the monitor, print a sample rhythm strip. The strip allows for artifact, confirm or shows any artifact, confirm electrodes are firmly applied and the cable's plugged in correctly. All right, so some of the interesting things that we have assistant devices, post heart surgery or trying to get to a heart surgeon. You may end up having some kind of type of device that's going to help the patient. Many patients have had open heart surgeries, and they've been performed for over the past 30 years. So you may have some assistant devices that may be helping a patient before they can get to it. So in the coronary artery bypass graft, there's a blood vessel from the chest or the leg is sewn directly from the aorta to the coronary artery beyond the point of the obstruction. All right, so you may have a artery bypass graft that's being done for your patient, all right, or percutaneous transluminal coronary angioplasty. These are two different type of procedures. This one's replacing the coronary arteries, that they'll pull veins out of the legs and use them for new coronary arteries. And then transluminal coronary angioplasty, it's a tiny balloon that they go into the heart with in the cath table, in the cath lab, and they'll inflate it inside the coronary artery and then usually put in a stent. All right, so patients who have open heart surgery procedures may not have a long chest scar because now they're doing them in such small little windows. Treat chest pain in a patient who has had any of these procedures as the same as a patient who's never had heart surgery. Does not matter. Some have had implanted cardiac pacemakers, and you will usually see those on the left side just below the skin. Cardiac pacemakers, what they do is that they will maintain a regular cardiac rhythm and rate whenever they're called on. They deliver electrical impulses through wires in direct contact with the heart or the myocardium. Implanted, usually right under a heavy muscle or fold of skin in the upper left portion of the chest. That comes very handy because when you're putting a defibrillator pad on, it's on the right side of the chest. Never put a defibrillator pad on top of a pacemaker or an IED that's implanted into the skin. All right, so there's the cardiac pacemaker there. This technology is very reliable, and if it does malfunction, though, the patient can pass out, they get dizzy, and they might be weak because it's not functioning properly. Automatic implantable cardiac defibrillators, they're used by some patients who survive cardiac arrest because they had VFib. It monitors the heart rhythm and it delivers a shock as needed. Treat chest pain patients with these devices like any other patient having a heart attack. This electricity is low and it's not going to affect you if it goes off while you're treating the patient. Sternal defibrillator vest, we really don't see those anymore. It's a vest, kind of looks like a vest, and it's got electrodes in it. It's attached to a monitor and it can apply shocks. There's not too many of those out there in the field any longer. Left ventricular assist devices, LVADs, okay, it's right on the outside of the chest. What it's doing, it's enhancing the pumping of the blood to the ventricle. It's connected directly to the heart. So it's, remember, don't be jiggling that thing around. Don't pull it. Don't try to pull it off the chest. It's supposed to be there for a reason. It's supporting the patient's ventricles in order to pump until they're eligible for a heart transplant. All right, cardiac arrest, the complete cessation of cardiac activity, absence of carotid pulse, was terminal before CPR, and external defibrillation was developed in the 1960s. Most people died from cardiac arrest prior to the 1960s. Here you go, there's an AED, automatic external defibrillator. It looks at, you've done this through your BLS class, so I'm not going to spend a lot of time on this, but it does deliver a shock that once you have applied it, and the first thing you do to apply these things is turn it on, and it cannot be applied on anybody unless they do not have a pulse. AEDs are relatively easy to use. There's several different models. This is a particular trainer model here, okay? Advantages, it can deliver a shock very quickly. It's easy to operate. Anybody can use it. And then ALS providers don't have to be on scene for it to be used. You use in a remote adhesive pad. It's a larger pad area equals more efficient shocks. Other considerations, though all cardiac arrest patients should be analyzed, not all of the patients get a shock. Okay. All patients in cardiac arrest should be analyzed with an AED. If they are systole or flatline, there's going to be no shock indicated. You won't see it on any screen or anything else. But if it says shock not advised, it's going to advise you to do CPR. Early defibrillation, got to happen. It's part of the chain of survival. The quicker we can defibrillate somebody, the higher the chances that they'll convert out of that bad rhythm that they're in. ALS and post-arrest care, we'll continue with ventilation, oxygen saturation. We want to maintain a blood pressure of at least 90 systolically, check their glucose levels, and transport them to a hospital. Integration of AED and CPR, work with the AED and the CPR in sequence. Okay, it's part of that BLS training that you just went through. CPR must stop while the AED performs its job. Otherwise, it will pick up your movement of the patient and it will not properly analyze and shock. Maintenance, follow the manufacturer recommendations, read the operator's manual, and document any AED failures. All right, so AED maintenance, report AED failures, and Manufacturers of Food and Drug Association, your company you work for will do that. Medical directions should approve written protocols for the AEDs, and you need continued education to continue using those things. All right, so emergency preparation. Make sure the electrical injuries, injure nobody. If you have a patient that is in cardiac arrest, don't defibrillate patients that are in pooled water. Don't defibrillate patients touching any kind of metal. Carefully remove nitroglycerin patches, shave hairy chest, determine the nature of illness or mechanism of injury. If there is spinal immobilization that's required, if it's a trauma patient that's unresponsive, we need to immobilize them, just in case. Here's your algorithm. This display shows the AED algorithm. You can look at this on slide 70. Begin chest compressions and attach the AED as soon as available and witness cardiac arrest. Follow your local protocols. After AED protocol is completed, one of the following is likely. You get a pulse or no pulse regained, okay, and no shock advised, or no pulse regained and shock advised, so you'll do it multiple times. Wait for ALS and continue shocks and CPR on scene. If ALS is not responding and protocols agree, begin transport when the patient regains a pulse or 6 to 9 shocks are delivered. An AED gives 3 consecutive messages every 2 minutes. So you'll be doing CPR, high quality CPR, in between for 2-minute periods. Cardiac arrest during transport, stop the vehicle. If you're going to defibrillate somebody, stop. You want to be careful when you're doing this stuff. Begin CPR if AED is not immediately available. Call for ALS, analyze the rhythm, deliver the shock as indicated, and resume CPR. Then continue resuscitation per your local protocol. Coordination with ALS. If an AED available, don't wait for ALS. Okay. Notify ALS of cardiac arrest. Don't delay defibrillation. Remember, the earlier we can defibrillate patients, the higher chance that you may convert them. All right, so management of spontaneous return to circulation, or what we call management of return to spontaneous circulation, or ROSC. If they get a pulse, okay, that's the deal. Monitor for respirations. Provide oxygen via bag valve mask at a rate of 10 to 12 breaths per minute, or 1 squeeze of the bag every 6 seconds. Get their oxygen saturation between 95 and 99%. Try to get a blood pressure. See if the patient can follow simple commands. And again, be calling for ALS. If ALS hasn't gotten there yet, head to the hospital. All right, that is the end of the cardiovascular emergency section. This review starts on slide number 76. Be sure to clock out to get full credit for this lecture. You can do this review at your leisure, and be sure to take your Quizlet for cardiovascular emergencies, and we'll see you next time. Thanks again.